This is a graph of appendectomy rates in the US over time. You'll notice that rates decrease throughout the 70s and 80s, but start going up again in the mid-90s. And while I'm sure you're all commenting your guesses as to why this happened, it wasn't one single thing. But one thing is for sure, for as long as appendicitis has had a name, surgical removal has been the gold standard. The New England Journal of Medicine published an article in 1935 saying, almost universally, appendicitis has come to be regarded as a surgical ailment. So I wondered, how did appendicitis become a surgical ailment in the first place? And then what explains that weird reversal of appendectomy rates in the 90s? Naturally, we start the story in ancient Greece. In the year 30 CE, a Greek physician named Aretaeus of Cappadocia wrote about a bunch of diseases, including what was likely appendicitis given how he described pus draining from an abscess on the abdomen, or what's called pointing. The thing is, he never actually saw an appendix. Dissection was considered a generally icky thing, and other than some scholars in Alexandria, any kind of academic dissection back then was done on animals. Like a couple years later, the famous Roman surgeon, Claudius Galen, described the symptoms of appendicitis too, but because he mainly dissected animals without appendixes, he never saw an appendix either. Also, let's get this out of the way now. Appendixes is the plural for appendix if we're talking about the body part. Appendices is for when we're talking about like a book appendix. Now, doctors started warming up to dissection again around the 15th and 16th century, but they didn't find the appendix right away. At least, not until we got to the Italian Renaissance, when a physician named Jacopo Berengario da Carpi did something particularly clever. See, before dissecting a cadaver, he would inject fluids into the blood vessels of the kidney and other organs to see what they would actually look like in a living human. And the idea that humans even had a circulatory system was still like 100 years away. So da Carpi was just thinking, this dry-looking thing is usually wet, I'll put some water in it to study it better. And among other things, this gave him a good look at a less decomposed looking appendix, which he formally described in his short Introduction of Anatomy in 1522, or maybe 1530, it's not really clear. He called it the sac intestine, which gave us our first formal description of the human appendix. It was a hollow tube around 8 to 10 centimeters long that hangs off of the cecum, the portion of the large intestine that receives digested food from the small intestine. That's why this thing also gets called the vermiform appendix. It looks like a worm. But these physicians still didn't know what it did. Like, there was a guy in 1579 who hypothesized that when fetuses pooped in utero, their feces were stored in the appendix. So they knew nothing, is what I'm saying. But they did learn that it could cause problems. In 1754, a German surgeon named Lawrence Heister gave the first formal description of inflammation of the appendix in this massive collection of case studies. Quote, I was dissecting the body of a malefactor in the public theater at Altdorf. I found the small guts very red and inflamed in several places, but when I was about to demonstrate the situation of the great guts, I found the vermiform process of the cecum preternaturally black, adhering closer to the peritoneum than usual. As I now was about to separate it by gently pulling it asunder, the membranes of this process broke, notwithstanding the body was quite fresh, and discharged 2 or 3 spoonfuls of matter. This instance may stand as a proof of the possibility of inflammations arising and abscesses forming in the appendicula. It is probable that this person might have had some pain in this part, but of this I could get no information. Heister wasn't sure what all that abdominal damage meant, just that the appendix could get seriously messed up. See, the appendix is a mostly hollow little tube, but every now and then, stuff can obstruct the tube and cause a buildup of bacteria. As a result, the appendix gets all inflamed, which is what's called uncomplicated appendicitis. But eventually, the wall of the tube doesn't get enough oxygen and starts to die off. After a while, the appendix can burst open and bacteria can start spilling out, becoming complicated or perforated appendicitis. Over the next 100 years, a bunch of surgeons and doctors confirmed what Heister had written. The appendix would get inflamed, but they didn't know how big of a deal it was. Maybe their cadaver died with appendicitis, not from appendicitis. But all this time, nobody had surgically removed one yet. And the first case report documenting an appendectomy wasn't even for appendicitis. In 1735, a doctor named Claudius Amyand wrote a case report about an 11-year-old boy who had a hernia between his thigh and his scrotum. The kid had had a hernia since he was little, but came to see Amyand because he had just swallowed a pin and his abdomen hurt. Plus, he developed a fistula that was draining pus at this point. Amyand thought this would be a straightforward surgery, but as he said, quote, this operation proved the most complicated and perplexing I ever met with, many unsuspected oddities and events concurring to make it as intricate as it proved laborious and difficult. It turns out the pin ended up in the kid's appendix, so Hyeon removed it surgically and became the first to document an appendectomy. Now, a surgeon named William Cooksley had removed an appendix a few years earlier in 1731, but didn't publish until 1742, so Hyeon gets the glory. Either way, it wasn't until 1759 that a surgeon took out the appendix because it specifically was infected, but doctors still had to figure out when it was worth it to do an appendectomy, because, as you can imagine, surgery was still super risky back then. And this means I get to bring up a familiar name, Baron Guillaume de Poutron. Medical students, you probably already know this name because of Dupuytren's contracture. By the early 1800s, he was one of the most famous surgeons in France, and one of the most influential teachers in Paris, and unfortunately, he got appendicitis wrong. Dupuytren thought that lower right quadrant pain came from the cecum, not the appendix, and since he was so influential, that mistake spread far and wide to become the leading explanation of abdominal pain for the early 19th century. He called the condition typhlitis, which referred to an inflammation of both the appendix and the cecum. It comes from the Greek word for cecum specifically, which is Typhlon. Then in 1830, a German student published a graduate thesis on lower right quadrant abdominal pain, and in that thesis, he repeats a lot of Dupuytren's ideas, including the idea that inflammation in that area comes from the cecum. But he does introduce a new term, perityphlitis, meaning inflammation around the cecum, which could implicate the appendix. Either way, the error was spreading. Now, throughout the rest of the 1830s, a Scottish doctor named James Copland gave a bit of an update. See, Copland was also a pathologist, which had only recently become a thing at that point. Pathology in the 19th century meant that a doctor would listen to a patient's signs and symptoms when they were alive, then when the patient died, the doctor or surgeon would do an autopsy and look for any wonky anatomy. Then they'd try to correlate those autopsy findings with other patients with similar symptoms. So, if you saw a bunch of people complaining of lower right quadrant abdominal pain, then found that they all had inflamed appendixes on autopsy, these early pathologists would assume that the burst appendix caused the abdominal pain. And while Copland had only seen a few cases of appendicitis personally, he noticed that symptoms tended to come on much faster and more acutely than the more generalized peritonitis. He also noticed that appendicitis could be deadly, or it could resolve on its own. But the field of surgery was about to change big time. Ether and chloroform anesthesia were about 15 years from becoming commonplace, and Joseph Lister's antiseptic techniques would come out in the 1860s, which meant that surgeries could be longer and less likely to get infected. These technologies would cause surgeries across the board to become more common. But there was one surgeon in particular that was responsible for an explosion in appendectomies, an American surgeon named Reginald Fitz. He wrote a piece called Perforating Inflammation of the Vermiform Appendix, with special reference to its early diagnosis and treatment, which he presented at the first ever meeting of the Association of American Physicians. This work changed the treatment of appendicitis overnight, because, among other things, this is where Fitz coins the term appendicitis. See, Fitz had identified a big problem. He realized that how doctors talked about acute abdominal pain was inconsistent, and since this kind of illness is potentially life-threatening, they needed to get it right and figure out how to start treatment without wasting time. Quote, "It appears that even the most recent systematic writers are by no means agreed as to the exact relation of inflammation of the cecum and that of the appendix to peritonitis and perityphlitis. The vital importance of the timely and appropriate treatment of the disease in question is becoming more and more apparent." So Fitz combed through hundreds of past cases of typhlitis and pelvic infections and concluded that most of the time, infections in that region were mostly due to the appendix, not the cecum itself. And he was clear that appendicitis would lead to gangrene of the appendix, causing infection and eventually death. So in this piece, Fitz strongly advocates for surgical treatment, noting, quote, "If after the first 24 hours of the onset of the severe pain, the peritonitis is evidently spreading and the condition of the patient is grave, the question should be entertained of an immediate operation for exposing the appendix and determining its condition with reference to its removal. If any good results are to arise from such treatment, it must be applied early." Later on, he noted that a third of the cases resolved without surgery, but he still erred towards surgery whenever possible, because he suspected that uncomplicated cases would eventually become perforated ones. So, you might as well make it like Uncle Joey and cut it out. It's important to note that up until Fitz's paper, if a surgeon took out an appendix, it was usually because something else caught their attention first. Like they'd go in to fix a hernia and come out with an appendix. This paper changed all that. Literally just a year after Fitz's appendix paper came out, a surgeon did the first appendectomy specifically meant to treat appendicitis. the patient even lived. A few years later, an American surgeon named Charles McBurney published a paper where he described how he approached diagnosing appendicitis. He'd start at the anterior superior iliac spine, which is that bony bump on the front of your hip, then he'd go about 2 inches towards the belly button. This became known as McBurney's point. If you poke it and it hurts, that's McBurney's sign. And when he removed an appendix, he'd make a cut at McBurney's incision, which, fun fact, he didn't actually invent, he just popularized it and got the eponym. Also, for those of you who were taught that McBurney's point is a third of the way from the ASIS to the umbilicus, please keep using that. I was just so entertained that McBurney's version of McBurney's point is different than like modern day McBurney's point. Now, in reality, there's a ton of anatomic variation out there, and the appendix isn't right under McBurney's point in most people. But when taken together with physical exam and blood work, pain in that area can still help a doctor diagnose you. Now, while McBurney and Fitz were preaching the good word of appendectomies, doctors were learning more about the physiology of the appendix too. And this started one of the most common anatomy myths of all time. In 1887, a surgeon claimed that since only a handful of mammals have appendixes, it was probably a vestigial organ in humans. It was left over from evolution, which means it didn't have a function and you could remove it without any negative effects. He claimed, quote, "It seems to me that the human being is better off without the appendix than with it, for it is nothing but a trap to catch cherry stones and other foreign bodies." So now surgeons didn't need to wonder whether cutting out the appendix did more harm than good. They had clean, painless surgeries, which all these top surgeons were talking about, and the appendix didn't seem like it did anything useful. And that means that we can revisit the New England Journal of Medicine quote from the intro. Appendicitis became a, quote, surgical ailment because the only thing it was good for was getting infected. Get rid of it, and you get rid of a liability. But even though it seemed straightforward, a couple of physicians weren't so sure it was the best strategy. By the early 1900s, doctors were starting to get data saying that appendicitis could resolve on its own, with a doctor in 1902 suggesting, hey, you don't need to force surgery. If the patient is too weak, you can just give them some morphine and wait for a bit. So throughout the 20th century, surgeons and doctors started to hone in on whether they needed to do all those emergency appendectomies after all. Like, was there a chance they were doing more harm than good by removing the appendix? Well, in 1913, a surgeon named Edward Corner wrote an article in the British Medical Journal saying that the appendix might have some kind of protective function. He starts his paper by describing the process of digestion and how, when digested food gets to the cecum, it hangs out there for a while in the form of feces, making it an ideal place for bacterial growth. The appendix, then, was a little lymphatic buffer in a high-risk part of the intestine, an intestinal tonsil, as Corner calls it. And Corner was onto something. I actually wrote an episode of SciShow a few years ago about this topic, but the appendix does have an immune function. Like, a few scientists have proposed that good gut bacteria live in the appendix and can repopulate the colon if you get diarrhea and wipe out your normal intestinal microbiome. So, can you live without an appendix? Totally. But this is one of the reasons our appendectomy graph starts sloping downwards. The more that scientists appreciated the role of a healthy appendix, the more they had to weigh the pros and cons of removing it. The other question that doctors had to ask was whether there was an alternative to appendectomy, because by the 40s and 50s, plenty of appendicitis cases had resolved on their own, and when antibiotics came out, doctors had another tool for a more active conservative treatment. And one of the more outspoken fans of this new treatment style was an English surgeon named Eric Coldry. In 1956, he wrote a piece in the British Medical Journal saying, "Look, I know it's tradition to use surgery, but I've been using a non-surgical approach for 25 years and they've been mostly fine, even when the appendix is ruptured." And he wasn't the only one. More and more doctors were documenting their patients' recovery with antibiotics alone, at least for uncomplicated appendicitis. Unfortunately, a doctor couldn't always tell whether an appendix had ruptured or not without opening up their patient. Clinical presentation only got him so far, and x-rays weren't helpful for soft tissues. But then the CT, or computed tomography, came out in the 1980s, and that was a game changer. Because unlike x-rays, which are flat, CTs give the doctor a more three-dimensional view of the anatomy, including whether an organ is bigger than it should be, like, for instance, if an appendix was inflamed or ruptured. And by the late 80s, early 90s, the use of CT to diagnose appendicitis had become commonplace, but it wasn't perfect. Like, the appendix might look inflamed in the CT, then surgeons would cut it out and find that it actually wasn't inflamed, or what's called a negative appendectomy. Fortunately, a negative appendectomy isn't the end of the world. I read a paper from 2007 that said even if surgeons get some of them, it's better than an inflamed appendix eventually perforating and needing to come out anyway, so a few are expected. Okay, so we've got all these things moving surgeons away from removing the appendix. But in the 80s, we've also got a major update to appendectomy surgeries themselves. A surgeon named Kurt Sem did the first laparoscopic appendectomy in 1981 and published the article in 83. And once it caught on, removing an appendix became safer and easier to recover from. These laparoscopic surgeries had lower infection rates and led to shorter hospital stays too. So let's go back to our graph. One of the things I haven't mentioned is that this graph was made by looking up surgeries reported as ICD codes, referring to the International Classification of Disease System. Prior to 1997, open appendectomy and laparoscopic appendectomy were reported under the same code in the US. When they finally got different codes, epidemiologists could tell how many of each type were being performed. And those numbers look like this. Open appies keep falling while that increase in total appendectomies comes entirely from the popularity of laparoscopic surgeries. And while this graph was originally published in 2007, laparoscopic appendectomy rates have since surpassed the open version for both complicated and uncomplicated appendicitis. But the big question is whether appendicitis patients needed surgery at all. Appendectomies had been getting safer, but still, maybe they were overdoing it. Maybe antibiotics could treat most cases of appendicitis. The first prospective randomized controlled trial, or RCT, to ask that question was published in 1995 in the British Journal of Surgery by two Swedish doctors, Eriksson and Granström. They recruited 45 adult patients with acute appendicitis. 5 of them refused to be randomized and chose surgery. The remaining 40 were randomly assigned to the surgery group or to the antibiotic group. The antibiotics group was treated with cefotaxime and tinidazole and observed for 2 more days. Then they were prescribed an 8-day course of afloxacin and tinidazole, which they took on their own. Then the researchers followed up with the participants on the 6th, 10th, and 30th day after they were admitted. They wanted to know about their pain and symptoms, but also get information about things like white blood cell count, whether there was a bunch of bad bacteria in their stool, and whether anyone in the antibiotic group would actually need surgery after all. After 30 days, there weren't a ton of differences between the groups. White blood cell counts decreased, inflammatory proteins decreased, and pain was down to 0. Although the antibiotics group got to lower pain levels sooner than the surgical group did. And while academic papers typically end with, here are the implications of what we learned, then say, more research is needed, this paper is even more conservative. The authors describe their results, then conclude with, 40 out of 45 patients would have been cool with just antibiotics. But despite the lack of their excited language, their results had practical applications. Because as long as they were looking at uncomplicated appendicitis, doctors might be able to prescribe some antibiotics and avoid the risks of the surgery. But of course, they'd need more data. Over the years, more researchers conducted their own RCTs comparing appendectomy to antibiotics. And after a while, researchers had enough studies to conduct something called a meta-analysis. These are studies that pool data from separate studies together to suss out larger trends. And there have been a couple, but I want to focus on 3. One's from 2010, 2016, and 2022. The 2010 analysis looked at 3 studies. That one I talked about from 1995, another Eriksson study from 2006, and another from 2009. The 2016 analysis looked at those same 95 and 06 studies, omitted the 2009 study, and included 3 more that had been more recently published. And the analyses were lukewarm towards antibiotics. They concluded that they led to fewer major and minor complications and prevented surgery for a while, but 22.6% of participants needed appendectomy within a year anyway, so there were trade-offs. The 2022 meta-analysis landed somewhere different, though. They included 8 studies which analyzed over 3,000 participants compared to the 1,100 from the 2016 analysis. They mostly cared about how often patients developed complications after their treatment, but they also looked at whether the antibiotics patients needed surgery later and how long the patients stayed in the hospital, their quality of life, and how often uncomplicated appendicitis became complicated. After compiling all the data, antibiotic therapy no longer had a lower complication rate, and they had a higher chance of getting readmitted to the hospital for appendicitis than in the 2016 analysis. And it wasn't because antibiotics got more dangerous. It was because the majority of appendectomies analyzed in the 2010 and 2016 analyses were open surgeries, and the majority of surgeries in the 22 analysis were laparoscopic, which are less likely to get infected than opens. Plus, the trial with the most participants, the APPAC study from 2015, accounted for about half of all participants in the 2016 analysis, which skewed the results. The authors concluded that antibiotics for uncomplicated appendicitis still had their place, like if there was a pandemic that shut down non-emergency surgeries. But now that they had more data, their optimism for antibiotic-only treatment may have been overhyped. So, to finally make sense of that graph, the pattern involves everything from antibiotics, less invasive surgeries, better imaging, and the very sexy ICD coding system. But beyond the graph, the appendectomy story is a great example of a pattern we see all the time in the history of science. A new treatment, like appendix removal, gets a ton of hype after successful clinical trials. Then when more people start using it, scientists get a more accurate idea of what it can or can't do. It's kind of like what scientists are learning about bacteriophage therapy, a topic you can learn all about in my video right here. But before you go, I want to thank my supporters on Patreon. Their funding makes these videos happen, and you can join them for as little as $2 a month. Thanks for watching, y'all. I'll see you in the next one.